Welcome to part one of endocrine alterations. Here are your learning outcomes and key terms. The endocrine system consists of glands located throughout the body that secrete chemical messengers called hormones. These substances are responsible for growth and development, metabolism, sexual function, reproduction, and mood stability. The endocrine, nervous, and immune systems all work together to maintain homeostasis of the internal environment of our bodies. The severity of the endocrine disorders can cause very mild problems to life-threatening conditions. Specific body signals trigger endocrine glands to release these hormones into circulation. And some hormones are regulated by chemical, hormonal, or neural factors. They have specific rates and rhythms of secretion. They're released either to respond to an altered cellular environment or to maintain the level of another hormone or substance. And they affect only target cells with the appropriate receptors. And these hormones operate within a feedback system. Both positive and negative feedback systems are important in maintaining normal hormone ranges, but negative feedback is the most common. So let's do a little brief review of your endocrine glands. So you have your hypothalamus, and that regulates the pituitary gland. It has many receptors that stimulate and inhibit the release of hormones. You have the pituitary gland, and that's called the master gland, and it's about the size of a pea, and it's divided into two parts: the anterior pituitary, which is responsible for growth hormone, thyroid stimulating hormone, ACTH, FSH, LH, and prolactin. And those are what you'll learn about those in OB. And then you have the posterior pituitary, and that's responsible for the release of ADH and oxytocin. Then you have the thyroid gland, and this is at the base of the neck, right below the larynx. It's two lobes on either side of the trachea, and it looks like a butterfly. And it secretes T3 and T4, and that is what we call thyroid hormone. Then you have your parathyroid glands, and those sit behind or on the back of the thyroid gland, and there's four of them. And they're responsible, those glands are responsible for the release of parathyroid hormone, and that regulates calcium. And then you have the thymus, which we've talked about in the past, and that's responsible for the production of T lymphs. Then you have the adrenal gland, and those are located on the top of each kidney. And those have an inner and outer portion, and they produce epinephrine, norepinephrine, ACTH, cortisol, androgens, and estrogens. Then you have your pancreas, and your pancreas is responsible for producing insulin and glucagon, and it also produces digestive enzymes. So like I said earlier, hormones are released in response to an alteration in the cellular environment. They are regulated to maintain certain substances or regulated to maintain other hormones. So throughout this lecture, you're going to see a lot about feedback systems. And so let's briefly talk about that right now. In the negative feedback system, hormones are released only when levels decline. And when levels rise, then the production of hormone is stopped. Your body has its own internal controller for maintaining temperature, pH, hormone levels, blood sugar, and other internal variable levels to keep them at homeostasis, which is the optimal internal state at which our body operates best. We're always talking about that homeostasis, equilibrium. The controller of homeostasis in most animals is the hypothalamus. Without this structure in the brain, we would have a very hard time functioning normally. So other examples of negative feedback, you've got the human body temperature. The hypothalamus of a human responds to temperature fluctuations, and it responds accordingly. If temperature drops, the body shivers to bring the temperature up. And if it's too warm, the body will sweat to cool it down. You also have human blood pressure. When blood pressure increases, signals are sent to the brain from the blood vessels. Signals are sent to the heart from the brain, and the heart rate slows down, thus helping control blood pressure or bringing blood pressure back down to normal. You also have the regulation of blood sugar in humans. When blood sugar rises, insulin signals the liver and muscles and other cells to store excess glucose. And some is stored in the body as fat, and others stored in the liver and muscle as glycogen. And then you also have the production of human red blood cells. And we've talked about that before. That is called erythropoietin, or erythropoiesis. A decrease in oxygen is detected by the kidneys, and they secrete erythropoietin. And this hormone stimulates the production of red blood cells. So these are just a few examples of feedback systems. Remember, with aging, different things happen to the body. And for the endocrine system, we see the organs start to atrophy, and there's weight loss with vascular changes. There's decreased secretion of hormones, and there's also a decrease in the clearing of hormones. Plus, there's variable change in the receptors that actually bind the hormones. So in what ways can the endocrine system dysfunction? First, you have hyposecretion, and that's the failure of the body to produce the hormone. So they're not producing enough. Or hypersecretion, where the body is producing too much. You can have a failure in the feedback system. You can have increased hormone degradation or inactivation by antibodies, and we'll see that when we talk about thyroid disease. Sometimes there's inadequate blood supply to the gland. Other times you see this ectopic source of hormones from non-endocrine glands, and we see that in some types of cancerous tumors. They can have an ectopic source of hormones. And then sometimes you just have target cell failure. So here you will see the pituitary gland, and that is a pea-sized structure located just below the hypothalamus, and it has an anterior and a posterior section to it. So this is just going back over what I talked about in a few slides earlier, that the anterior pituitary is responsible for ACTH, growth hormone, prolactin, FSH, LH, but the one that we're really going to pay attention to, or actually two, is ACTH and thyroid stimulating hormone. And these hormones, especially LH and FSH, those are the first two, you're going to be spending some time on those in OB. And you have the posterior pituitary. And the big one with posterior pituitary is the secretion of ADH. So the first thing that we're going to talk about is diseases of the pituitary gland itself, and we're going to talk about posterior and anterior gland problems. I find this slide, and you can find this in your book, very interesting because it really shows you what this small pea-sized gland is responsible for doing in the body.
All right, so the first set of diseases that we're going to talk about are the diseases of the pituitary gland. And the pituitary gland is a pea-sized gland that sits right below the hypothalamus, and it has an anterior portion and a posterior portion, and they both do different things. So the first thing that we're going to talk about is the posterior pituitary. And remember, this is all regulated by the hypothalamus. So the hypothalamus will secrete certain receptors or certain hormones that tell the pituitary gland to release other hormones to target organs. So the first thing that we're going to talk about is the posterior pituitary. The posterior pituitary, its major homeostatic function is the control of plasma osmolality and is regulated by ADH. So normally what happens is if our plasma osmolality increases, the hypothalamus will be stimulated and the osmoreceptors will be stimulated, and it will increase our thirst receptors, and so we'll drink water. The other thing that will happen is the hypothalamus will signal to the posterior pituitary to release ADH. And you remember what ADH is, antidiuretic hormone. And what that will do is it will target the kidneys, and it will tell the kidneys to retain H2O. So H2O is then retained by the kidneys. So this is what normally happens when you have problems with thirst or increased plasma osmolality. So the first two diseases that we're going to talk about are going to be related to ADH.
So our first disease is SIADH, and that's syndrome of inappropriate antidiuretic hormone. So just think about what those words say. Inappropriate antidiuretic hormone, excessive secretion. So excessive secretion. So just think about what that can do. If you have too much of antidiuretic hormone, you're going to have too much water retention, and that's what we're going to talk about. What causes SIADH? We look at head trauma, tumors, some infections, some patients that are post-stroke, emphysema, and meningitis. And it's a very simple pathophysiology. Your body is secreting excessive ADH, and that causes the kidneys to retain water. And then what we have is dilutional hyponatremia. So remember how we talked about fluid and electrolytes back in Module 3. And we talked a lot about how the body can cause plasma osmolality to be increased or decreased, and that can be due to water loss. So this is a water gain. So the normal serum sodium that's in the body is going to be diluted by too much water. So these patients are going to have weight gain, JVD, crackles in their lungs. They're going to have decreased urinary output because the kidneys are retaining that water. Edema. They're going to be hyponatremic, have hypoosmolality, and they'll have hypertension just because of all the fluid that they're holding on to. All right, the next one is diabetes insipidus. Now, guys, please remember, this has nothing to do with blood sugar. All right, I'm going to say it again, has nothing to do with blood sugar. The reason that this has the name diabetes is because some of the symptoms or clinical manifestations are the same as diabetes, but this has nothing to do with blood sugar. All right, what this is caused by ADH insufficiency. So there's not enough ADH. So you'll notice that there are two different types of etiology. First, you have neurogenic. Um, Inefficient amounts of ADH it can be caused by damage to the ADH secreting cells in the hypothalamus. And this can occur from closed head trauma, intracranial brain tumors, and sometimes just neurosurgery itself. Then you have nephrogenic, meaning kidney, and it's an inadequate response to ADH. And that's usually due to medications that are given, and those sometimes can damage the renal tubular. So the renal tubular cells start to become defected, and so they don't reabsorb water as effectively as they should. So you'll see that you either have a decrease in ADH secretion or an insensitive ADH receptor. So one way or the other. They both lead to the nephron does not reabsorb water. So the body loses high amounts of water in the urine. So the patient becomes very dehydrated. And now your balance of water and salt are off again. So you have a lot more concentration of salt than you do water. So this patient will have hypernatremia. So think about this person being really, really, really dry. Polyuria, polydipsia, their skin tuger is really, really poor, dry mucous membranes, hypotension because they just are fluid volume deficit, hypernatremia, and hyperosmolality. So this slide talks a little bit about the sodium and water concentrations. And what you're going to look at next is the way that I see SIADH and diabetes insipidus.
All right, so let's take a look at how I see SIADH versus diabetes insipidus. So with SIADH, remember this is excessive ADH secretion. So the body is retaining fluid, it's water. And so what happens is the patient is retaining water, so the serum sodium in the body, so the serum, remember the serum sodium in the body is going to become low because it's going to get diluted. And then the serum osmolality or the plasma osmolality, so we're going to put plasma osmolality, that is going to be low as well. And even think about the specific gravity of urine. So if the patient's holding on to water, they're not urinating. So the little bits of urine that is released, the specific gravity of that urine is going to be high. And sometimes we can see it greater than the concentration of 1.030. So think about this patient is going to have all of this weight gain. And I always think about the Michelin Man, the big white Michelin Man in Ghostbusters. I think about him with SIADH. So this patient is definitely going to have problems with hyponatremia and hypoosmolality, serum osmolality. All right? All right, so now let's look at the difference between diabetes insipidus and SIADH. So diabetes insipidus, what that is a decreased ADH secretion. So the body's not able to hold on to water. So when I look at diabetes insipidus, I think about this poor little guy here who's really, really, really thirsty, having to stay by the bathroom because he's having to urinate a lot. So with these patients, what you're going to see is a lot of polyuria, polydipsia, but because they're urinating and not holding on to water, their serum sodium will be high because of the concentration. So remember, you're losing more water than sodium. So your serum sodium is going to be high, and your plasma osmolality is going to be high as well. So we're going to call this patient hyperosmolality. So what about the urine? So think about that. What's going to happen with the urine is that specific gravity is going to be really low. You're looking at less than 1.010. So these patients are going to have hypernatremia and hyper serum, now remember, serum osmolality. So when I think about these two diseases, this is how I see them.
All right, so the next thing that we're going to talk about is thyroid and parathyroid glands. The thyroid gland are two lobes. They lie on either side of the trachea, and their job is to regulate and secrete thyroid hormone. So thyroid hormone is secreted because there is something called TSH, and that's thyroid stimulating hormone. And we're going to talk a little bit about this in the next few slides. So don't overthink this slide too much just yet. There's also the parathyroid glands, and these guys are small glands. There's 4 of them that lay behind the thyroid gland itself. And their main job is to increase serum calcium and decrease serum phosphate. And so what you see, this right here is the thyroid gland, and it lies, and it looks kind of like a butterfly here. And then if you look behind it, these right here are your parathyroid glands. The next disease processes that we're going to talk about are alterations of thyroid function.
So the next set of diseases are going to have to deal with the anterior pituitary gland. And this is all based on the thyroid and thyroid function. So what happens is, this is a great example of negative feedback. So if our thyroid gland isn't producing enough thyroid hormone, which is T3 and T4, and these guys control basal metabolism. So if our bodies feel like there's not enough, it will go up and tell the hypothalamus. And it'll tell the hypothalamus to release a hormone called thyroid releasing hormone. So that will be released by the hypothalamus. And thyroid releasing hormone will then go down to the anterior pituitary and tell the anterior pituitary to release thyroid stimulating hormone. And what's going to happen is that hormone is going to come down and it's going to stimulate the receptors on the thyroid itself. So thyroid stimulating hormone is going to stimulate these receptors to then stimulate the thyroid to release T3 and T4. And once there is enough T3 and T4, then what's going to happen is it's going to go back up until the anterior pituitary and the hypothalamus to stop making TRH and TSH because the body has enough and it sits at equilibrium. And if the body then needs more T3 and T4, the process will start all over.
So basically, this slide is just showing what I just talked about and how the hypothalamus is releasing thyroid-releasing hormone, and that tells the anterior pituitary to release thyroid-stimulating hormone, which then tells the thyroid gland to release thyroid hormone, which is T3 and T4. So this is hyperthyroidism, and that is an increase in secretion of thyroid hormone. All right, so there's a few ways that can be a cause or etiology of hyperthyroidism. One is Graves' disease, and that is an autoimmune problem. So the body produces immunoglobulins that actually stimulate the thyroid gland itself. Or there are things called toxic adenomas or goiters, and that's when the gland itself enlarges. So there's a video to help you really understand this. So then that's on the next slide, but we're just going to go through it real briefly. That the patient will have elevated T3, T4, which is thyroid hormone. The body does not respond to the negative feedback system. So the patient is secreting this hormone, and the body's trying to say, turn it off, and it stops secreting TSH. So these patients will present with very low TSH, serum TSH, but very high thyroid hormone. In the end game, they end up with a very high basal metabolic rate because thyroid hormone, that's what it does. It regulates our basal metabolism. So these patients are, they're going to have a lot of weight loss. And sometimes it's hard to convince these patients that they need to get this, this corrected because they like the weight loss. They also have nervousness, so they'll say that they feel very anxious. Their reflexes are very hyperactive. So if you are suspecting that they have hyperthyroidism, when you're testing those reflexes, you want to stand back because you will get kicked or hit. They can be very diaphoretic, tachycardic. Their systolic blood pressure will increase. And if it goes on too long, patients can have what's called exophthalmos, and that's where the eyes look like they're bulging out of the head. If this isn't corrected, the patients can go into what's called thyroid storm, and that's when these excessive amounts of hormones are released into circulation, and it's rare, but can cause death within 48 hours if not treated because the temperature will increase extremely. It will increase a lot. The patient will become very tachycardic, have malignant hypertension, cardiac arrhythmias will start to occur, and then delirium.
All right, so remember when we talked about the negative feedback system. So normally, when the body has enough T3 and T4 made, the body will go and tell the anterior pituitary and the hypothalamus to turn off the two hormones, which is TRH and TSH. So turn those off and stop making thyroid hormone. And so this basically causes the patient to have now a normal thyroid hormone. And if the thyroid hormone drops or, decreases, then the system will start all over. The thyroid will tell the hypothalamus and it'll tell the anterior pituitary, hey, I need more thyroid hormone. So the hypothalamus will turn on its TRH. It'll stimulate the anterior pituitary to turn on TSH, and TSH will come down and will bond with the receptors, and the thyroid will make T3, T4. And once there's enough, it'll go back up and tell the system to turn it off. So that is how this is normally regulated. But wonder if something bypassed this regulation and wanted to do its own thing. Let's say that it went rogue. And that's what Graves' disease is the body just produces what we call TSI, and that's thyroid stimulating immunoglobulin. So this is something, just in its name itself, thyroid stimulating immunoglobulin. So what it's going to do is the same thing as TSH, but it's not controlled by the hypothalamus or the anterior pituitary. So it's going to hop onto these receptors and it's going to tell the thyroid to make T3 and T4. But there's going to be really high levels of it. So the body tries to say, hey, turn off the TSH. I don't need any more T3, T4. Please stop. But the body or the anterior pituitary is not in charge of this. The TSIs are creating this havoc, and they're going to continue to create it because nobody can turn it off. So this is a dysregulation of the negative feedback system. The negative feedback system cannot work. It cannot turn these off. So with these patients, what you'll see if you do blood work is these patients will all have a high T3, a high T4, and a low TSH. And why is that? Because the body's telling the anterior pituitary, shut off the TSH. So it does. The body stops making it. But that's not what's controlling these guys, right? Nothing's controlling them. So they're continuing to increase this T3, T4, and the body's shut down the TSH completely. So these patients in blood work will have a high T3, a high T4, and a low TSH. All right, so the next thing that we're going to talk about is goiters, or the tumors that can cause hyperthyroidism. So going back to the same thing, the normal system as we've talked about. So this has nothing to do with those immunoglobulins. So the body produces TSH, and it stimulates the thyroid to make T3, T4. Okay? But what happens is this guy here, this is our gland enlargement or goiter, it basically acts on its own. And it causes the body to make T3, T4 as well. So what we have in this system is, again, high levels of T3 and T4. So what will happen is this will go up. It'll tell the anterior pituitary and the hypothalamus to turn off TSH. So it's going to turn off all the TSH. But this goiter is still producing T3, T4 because it's not being controlled by TSH. It's controlling itself. So same thing is this guy's a little bit rogue as well. So these patients will also have a high T3 and a high T4 and a low TSH.
This is just a great visual representation of how somebody will present with hypothyroidism, and I love this because her pants are held up with a safety pin because she's lost so much weight. All right, so this is just the opposite. This is hypothyroidism. So there is a decrease in secretion of thyroid hormone. There are a few causes, all ending up in the same thing, is damage to the thyroid gland itself. So it can be congenital thyroid defects, an autoimmune disease called Hashimoto's. Hashimoto's produces another type of antibody that actually destroys the thyroid gland itself. And then you have surgical removal or an infection and inflammation of the thyroid called thyroiditis. Any of these will cause loss of thyroid function. And if the thyroid is not functioning like it's supposed to, there will be a decreased production of thyroid hormone. The body's going to respond by saying, hey, I need more thyroid hormone. So it's going to produce more thyroid stimulating hormone. And what we see in these patients are very slow basal metabolic rates. So these patients are going to be very fatigued, complain of weight gain, probably constipation, delayed reflexes, feeling very cold and sluggish.
So let's look at hypothyroidism. What this is the thyroid gland is no longer able to produce large amounts or even normal amounts of T3, T4. So either it has been destroyed by an autoimmune disease called Hashimoto's, and what Hashimoto's does is it produces antibodies that attack the thyroid gland itself. And so it destroys the thyroid gland. Or you can see surgical removal, or sometimes patients can have an infection or an inflammation in the thyroid, and that's called thyroiditis, and that then destroys the gland itself. So the gland can only produce very low levels of T3 and T4. But nothing's wrong with the hypothalamus or the anterior pituitary. They're working normally. So what the body's going to do is it's producing very low levels of T3 and T4. So it's going to tell the anterior pituitary and the hypothalamus, hey, I need more TSH because I don't have enough thyroid hormone. So the body continues to produce TSH, trying to stimulate a broken gland because it doesn't recognize that the gland is broken. It just recognizes that it's not producing enough T3, T4. So it's going to go up and tell the anterior pituitary, hey, make some more thyroid stimulating hormone. So what's going to happen is the body is going to produce more TSH, and TSH is going to try to stimulate this gland, but the gland's broken, so it can't be stimulated. So what you see in these patients are low levels of T3 and T4 because the gland cannot produce it, but they're going to have high levels of TSH because the body's overproducing TSH in response to low levels of thyroid hormone.
This is also a great representation of patients that are experiencing hypothyroidism. If you look at this picture, this is going to compare hyper to hypo function. So you can see the difference of clinical manifestations the patients may experience. All right, moving into alterations of the parathyroid function.
So the next set of diseases we're going to talk about are parathyroid disorders or parathyroid function disorders. So what we see is the parathyroid gland, and this gland lies behind thyroid tissue, and there's 4 glands, one on each lobe of the thyroid. And this primary goal of the parathyroid gland is to produce parathyroid hormone. And parathyroid hormone is produced when there are low serum calcium levels. So if the body has a low serum calcium, it's going to tell the parathyroid gland to stimulate parathyroid hormone. And the hormone is going to pull calcium from 3 different areas. It is going to pull from the bone. So these are our bones. And it is going to promote resorption. So it's going to PTH is going to promote resorption from the bone. So it's going to pull that calcium from the bone. The next thing it's going to do is, this is our kidney. And parathyroid hormone is going to promote renal reabsorption. So PTH is going to help the kidney reabsorb calcium. And then I'll put calcium here as well. All right, so it's going to pull the calcium out of the bone into the serum. It's going to pull it out of the kidney into the serum. And it's also going to promote, and this is our GI tract. And what it's going to do is it's going to promote absorption. So it's going to, PTH is going to promote absorption from the GI tract. So it's just going to pull the calcium out of there as well. So those 3 ways that calcium is going to be pulled out, because remember, our bodies don't make it, they store it. Okay, so it's going to pull all of this out, and what you're going to have is an increase in serum calcium. And then what that's going to do is it's going to go up to the parathyroid gland, and it's going to say, okay, turn off PTH. And the parathyroid gland will turn off the PTH, and then the parathyroid hormone will stop absorbing or resorbing from those 3 areas. And this is normally what happens in the body when our serum calciums decrease.
And this is just a picture representation of what I just spoke about in the last slide. First thing we're going to talk about is hyperparathyroidism, and that means there is an increase in secretion of parathyroid hormone. So hyperparathyroidism is a condition characterized by the overactivity of the parathyroid gland, and it's, those 4 glands that sit behind the back of the thyroid. In this condition, there is this excess production of parathyroid hormone. Normally, the parathyroid glands secrete PTH to help maintain balance of calcium, which we've talked about. So when the blood calcium levels fall too low, the parathyroid gland secretes PTH. In primary hyperparathyroidism, we see that there are adenomas or gland hyperplasia, which is causing the gland to secrete more PTH. And then you have secondary, which is chronic hypocalcemia, and that's due to renal failure, because the kidneys can't activate vitamin D, and vitamin D is necessary for the formation of or the absorption of calcium. So with renal failure, we see chronic hypocalcemia. So with the patho, we see this excess secretion of PTH. And like we talked about earlier, it's going to pull from three sections, three areas. And the feedback system is going to fail. The feedback system, just because these guys are secreting just kind of like the thyroid was doing, it's doing its own thing. So the feedback system fails, and the calcium is being pulled from all of these areas. And one of the things that we really have to think about is think about those bones. And if you're constantly pulling calcium out of the bone, it's going to make that bone become fragile. So these patients are going to have deep bone pain and pathological fractures. They're also going to have hypercalcemia. You can see renal damage because if we're pulling all of this calcium out, it can cause calcium stones to form and cause renal damage. So we can see those kidney stones, and we can also, because of the elevated calcium, we can also see cardiac dysrhythmias. And the next one is hypoparathyroidism, and this is a decrease in secretion of parathyroid hormone. So basically, two ways that you can have this happen is one, there's been damage to those parathyroid glands, or they've been removed accidentally. You can see this happen when patients have thyroid surgery. So through thyroid surgery, those glands can be nicked or accidentally removed. Either way, there's a destruction of the gland, so the gland is not producing PTH, and if it's not producing PTH, then the bones, the kidneys, and the GI system aren't responding with the reabsorption and absorption of calcium. So what we see is these decreased calcium levels. The body goes up and tries to tell the gland to produce PTH, but the gland just can't do it. So these patients, if you look very closely at their clinical manifestations, they're all related to hypocalcemia.